what it did is it really exposed that there were some gaps in terms of how we were addressing whole person care.
What would you say to that very challenging question?
I'm going to say something very controversial. I think it is not just every entity you just mentioned responsibility.
Yep.
I also think it's the individual person's responsibility.
Sure, yeah. Hi, welcome to System Logic Podcast. I'm Jason Lee. Today, we have the pleasure of being joined by Paige Brogan, who is currently the business driver for provider enablement at Blue Shield of California, but is leading the role of principal of CalAIM, which is a major program here in California, Blue Shield of California, and you've been a preeminent voice around the transformation of how Medi-Cal program has run, and particularly amongst the state and at Blue Shield. Paige has been instrumental in bridging the gap between state-level policy, technology, and the delivery of whole person care. So, Paige, thanks so much for joining us.
Jason, thank you so much for allowing me to opine on the state of CalAIM.
Absolutely, absolutely. So, you and I have known each other for a while. Tell the audience a little bit about how you got into healthcare. You've been a veteran for about 20 years or so. Lots of different roles. Tell us a little bit about how you got into it and some of the highlights of your career so far.
Thank you, Jason. I actually started back at Kaiser Permanente doing medical review back when we actually did medical review.
Yeah.
I fell in love with healthcare because I felt as it was a place where I could apply business acumen, critical thinking, technologically forward strategy in a way that actually delivered to help people that I think really need help the most. I think healthcare is incredibly complicated. It's something that is fundamental to everything that we need. And the opportunity to support the healthcare delivery system was incredibly exciting to me.
Mm-hmm.
I've had the fortune of working on some large-scale healthcare initiatives, such as the Affordable Care Act, and now California innovating and advancing Medi-Cal.
Yeah, absolutely. You know, and for those who are not familiar, Kaiser is one of the largest and most quality-focused organizations from a healthcare standpoint in the country. Tell us a little bit about what you learned about delivering whole person care through working with that organization, and how you've taken that on to some of the other roles that you've had in the last decade or so.
Kaiser is interesting in that it was really a pioneer. If you think back to the 40s and 50s when Henry Kaiser first envisioned this notion of employees sort of contributing to their own health coverage and contracting with providers, they obviously have an integrated model, which is unique in the healthcare delivery system, right? Most major players in this space contract with providers. At Kaiser, they have in-house providers, and of course, they now have the Bernard Tyson School of Medicine, which is really fascinating in terms of they're really building up capacity in a way that informs physicians to join that integrated model.
We'll talk about more about how we are supplying the access issue in a second too. But for clarity, the Kaiser model has an integrated health plan with the acute facilities and the doctors, right? Is that right?
That is correct. Yes.
Okay, yeah. So with that model, then they're able to focus on a different way of delivering care.
I don't know if it's a different way of delivering care. I think every major healthcare delivery system in this country wants to deliver care in a way that is appropriate, compassionate, empathetic, and delivering on the needs of their members. Kaiser just does it a little bit differently, but I think ultimately, whether you're from United or you're from Anthem or you're part of the Blue Shield, you're part of the Blues, I think all major health plans in this country really have the right ethos in mind. Now, I know there's been a lot of publicity around, sort of the model being profit-driven, and I can see those points, but I will say that having been in this space for decades, all major players in this space really, really do want the best outcome for their members.
Yeah, and I think in a state as large and complex as California, it really takes quite a bit of coordination, quite a bit of collaboration amongst all of the different types of organizations to really make an impact. And so you have been, to your credit, incredibly involved in helping to drive some of that, at least at the health plan level. Tell us a little bit about your role more recently with Blue Shield of California and some of the work that you've done with CalAIM.
So CalAIM was really born out of the expansion of Medicaid that happened because of the Affordable Care Act. And what it did is it really exposed that there were some gaps in terms of how we were addressing whole person care. Instead of just addressing the straightforward clinical needs, the Medicaid on a federal level population really needed so much more. They needed other needs addressed, such as housing insecurity, food insecurity, behavioral mental health issues. And so California really took the lead. There are other states that have done pieces of this, as New York, Illinois, Pennsylvania, Washington, Oregon, other states. But California really took a strong advocacy role to enact change on behalf of the membership to increase visibility to other needs. And I think the state did a remarkable job in exposing this problem of whole person care. I think that there have been enormous successes. I'm really so proud of the work that we've done over the last 5 years. I think that there are some fundamental structural changes that will need to take place. It wasn't just a program that you could enact some new initiatives and then walk away from. It really is a fundamental restructuring of what Medicaid and Medi-Cal here in California really represents. And then with the passage of H.R. 1, the Big Beautiful Bill, in July of 2025, that's definitely jeopardized the opportunity to really capitalize on all the hard work that we've done over the last 5 years.
Yeah. So you were talking a little bit about how California is driving that forward. They were hitting a bump perhaps with the Big Beautiful Bill. Let's take a step back and think about, or let me ask you a little bit about how the implementation of CalAIM has transpired over the last 5 years. Certainly, a lot of the audience that we have are medical group leaders, health system leaders, and as you think about the challenges of coordinating care and looking at a whole person care for the Medi-Cal population, or Medicaid in a lot of other states, what were some of the early challenges that you came across as one of the leaders looking at this program, and how did you address some of those early on as this was getting rolled out, maybe even 4 or 5 years ago?
I think there was a lot of momentum to make things happen very quickly. So bring on these new enhanced care management providers, bring on these new community support providers, and both the infrastructure from a health plan perspective and the providers really didn't have enough time to understand what the requirement was. And I think, again, everyone's heart was in the right place. Everyone wanted to do the right thing for this population. The challenge was, how do you get some of these non-traditional providers contracted? How do you provide education to these new providers? How do you fulfill reporting requirements to the state? So you sort of were forced to, you had this challenge of, you wanted to be compliant, you wanted to do the right thing by the member, you wanted to also make sure that financially it was something that was sustainable. And I think, one of the things that we need to realize about how it works with the Medicaid is, you're getting funding from the state, you're getting funding from the federal government, and then there was a lot of funding that was provided to providers to stand them up, right? And we did that so quickly. And we didn't really have time to take a pause and think, are we really doing this the right way?
You mentioned earlier the notion of some non-traditional providers. What do you mean by that? Are you talking about some of the FQHCs? Are you talking about some of the APPs? When you say non-traditional providers, help me understand a little bit about where that group of providers is coming from.
Sure. So think about your community health workers, right? Those with lived experience that are helping assist members in a emergency room situation or in a brick and mortar situation. You're talking about street medicine providers that are actually literally meeting members where they are.
I see.
You're talking about the doulas population, right? These women that are brought in to help birthing mothers. So these are providers that were non-traditional, that are not used to working with managed care plans.
I gotcha. I see. So whereas the physicians and even some of those allied health professionals will have in-network agreements with the Blue Shields of the world, maybe your doulas, your street health teams, those folks are traditionally not contracted directly with some of these health systems and health plans. I got you. Okay. And as those teams are integrated into the model, what are some of the ways that you guys initially were thinking about? How do we get those folks plugged in? I have seen some of those street health teams walking around with web-enabled iPads, and they're working with folks, people that are in and out of homelessness, that you're helping to try to document those people. Tell us a little bit about how the program of CalAIM particularly might have supported some of those efforts.
The heart of CalAIM is this ethos of no wrong door, that we're meeting members where they are. And I think that's really fundamental when you think about all the infrastructure that's required. So when you think about how are we finding people where they are? How are we ensuring that they are contracted with a managed care plan? And then how are we continually supporting their health journey? So if somebody gets referred and they're out in the streets, how do we close the loop and make sure that they actually went to that referring provider?
I follow.
How are we following up with them to make sure that if there is serious mental illness, if there is substance use disorder, if there are behavioral health issues, housing insecurity, food insecurity, how are we making sure that we are continually reaching out to that person? So this whole notion of, whole person care, meaning that we are embracing all parts of it and we're following through on all of this, that was a challenge and will continue to be a challenge. And especially in light of the fact that a lot of these providers were given grant money in the very beginning, that grant money is running out.
Yeah, right.
I mean, we're seeing investors coming in to say, oh, should I invest in an ECM, enhanced care management provider? Should I invest in a community supports provider? Another interesting component of this is community supports were initially called in lieu of services. The idea being that if you offered asthma remediation or sobering centers or home modification or medically tailored meals, then that would prevent a member from utilizing the emergency room, right? Because they'd be receiving these other services, and then that would provide a conduit to reaching their health goals, as opposed to utilizing emergency room services. So in theory, it's health plans, you're saving money, but you're solving to the member need.
Right. That's where the in lieu. Now, did you come across very much pushback or static from the health systems, right? The providers, the medical groups at all, where there was some concern that some of these services ought to be provided by them, or some of these services were reducing the amount of dollars available for quote unquote more traditional healthcare services. How did that play out in your work? Because I know a lot of health systems were at the table when some of these programs were developed and rolled out, right?
Jason, I love that you used the word at the table, because one of the things that I think is really a fundamental outcome of the work in CalAIM is collaboration. So you really saw health plans, community-based organizations, correctional facilities, the state really coming together in a way that you didn't see before. And I really want to emphasize that we have this picture of managed care plans and even providers as, financially focused. And obviously everyone has to stay solvent. But I will say, in my experience with CalAIM, everybody really had the best interest in mind.
Yeah.
Everyone really wanted to see better outcomes for members, better outcomes for people that are of the most vulnerable that we have in the state of California.
Yeah.
And so I don't know that there was pushback so much as there was just, how do we get this done? How do we really deliver on this mission of CalAIM, really delivering in a way that had significant member outcomes? And I think I think that it's still a challenge. It's a hard population, and the way that the state rolled everything out, all up to DHCS, in case you're listening, it was a real challenge. Yeah.
I can imagine that there's a lot of uncertainty because it's such a unique program. Were there any other states in the country that there was at least some modeling after, or that we were able to take some from a small, programs in smaller states, perhaps? Because certainly there are flavors of what we're doing in California that might have popped up in other states. Were there any that you guys pointed to particularly that, this seemed like it worked in, Vermont or a smaller place or what have you?
Sure. Well, interesting enough, Johns Hopkins actually had a class, their School of Medicine actually had a class on CalAIM.
Did they? Recently?
They did.
That's
this
amazing.
was a couple of years ago.
Okay.
Because they were really looking at, what is California doing? And California's always been an innovator in this space. A third of all Californians are on Medi-Cal.
Right.
Over half the babies that are born in this state are Medi-Cal babies. So we have a very large population that's dependent upon this really critical program.
Yeah.
So yes, I mean, the correctional facility transition, so this is a program whereby we connect people that are exiting a correctional facility to a managed care plan to have continuity of care, continuity of medication adherence, continuity of any behavioral mental health issues. Yeah, you've seen that in New York. You've seen that in Oregon and Washington. I know Illinois under Governor Pritzker is doing a really interesting program where they are really literally having people go door to door, knocking on people. And this is providers, these are community-based organizations. There's a whole consortium where they're literally knocking on people's door to see, are you getting the care you need? What care do you need?
Right.
So there's a lot of programs that have kind of borrowing from what California has done. The question is, a lot of these programs are so grant-based, whether they're grant-based from private entities or from the federal government, and then of course the state governments.
Right.
So how sustainable is that?
Yeah. No, and I think taking a more holistic, value-based oriented or whole person perspective on care it's going to be a continual evolution. Obviously, there is a financial motive in all of these health plans and whatnot, and so getting to a place where everybody feels like an investment in a lot of what has transpired in CalAIM and a lot of these community-based services and whatnot is going to be a positive all around. Like I said, a lot of the medical group leaders that are in our audience, they think about how can we support and how do we connect with some of those folks, right? And so what I'm curious about is the data connectivity piece, right? How do you know that when, John Doe is cared for by a given, ED and then is on the street for, various reasons and then is trying to get primary care, like how does all of that stuff kind of get all connected and what are some of the challenges and successes that you guys have had in overcoming some of those?
One of the central things that we really wanted to focus on was what does our risk stratification look like, right? So how are we identifying people? And it's interesting because you'll hear a lot of terms around high utilizers and low utilizers, right?
Okay. Utilizers of services is what you're saying? Yeah.
Exactly.
Okay.
And I really wish we could change the language because when you hear low utilizer, you're immediately thinking, oh, that's a low dollar amount. You hear high utilizer, you're thinking that's a high dollar amount.
Yes.
And I really would like to reframe the language to these are people that are utilizing services because there is an unmet need. So, if we could change it to, sort of needs-based.
Yes.
And, it's interesting because we talk a lot about, how do we find those needles in a haystack? And what I think is going to be really interesting is the state of California did launch a population health management system called Medi-Cal Connect in July of 2025.
Okay,
and
not that long ago.
Right, so they're still gathering data from plans. They're still working to really improve the system. And, shout out to Dr. Nash if she's listening, because, she's really spearheaded this program and it's been absolutely incredible. Is it real time though? No, it's not.
Yeah.
And so when you're utilizing data based on legacy claims, it makes it very hard to be real live time.
Yeah.
In terms of identifying.
How much of a delay is it as far as you know? Is it like months? Is it years?
It's a couple months.
Couple months. So, okay. Yeah. That's a little bit of too much of a lag, I think, to be effective.
Right.
Or fully effective. I mean, there's some level of effectiveness, but.
So how are we really working together? I mean, I think you make a really good point around. It needs to be a collaborative effort between the providers, the plans, the counties, all of the different players, and even the community-based organizations. We know that a lot of our Medi-Cal population utilizes churches and community kitchens and community events where they are getting in not just care, but they're getting information.
Right.
And they're sharing information. So we really need to up our game in that the traditional encounters that you would get at a brick and mortar are not as important as some of these other data points. So, is there a way we can find out that, Jane went to a church event and, it was discovered that she has housing insecurity or she has food insecurity and maybe she's exhibiting signs of early diabetes, right? And so how can we get that information and how can we as a health plan process that information quickly and efficiently and then are able to reach out and say, hey, you know what? We recognize that this might be a potential risk for you and we're going to bring you in for treatment.
So let me ask you this question, and for me, this is kind of a fundamental thing is, do you believe that the health plans, are, since they're taking on the risk of some of these, of the health of these various populations, are ultimately responsible for setting up these programs and in large part funding the work that goes on in these programs? Or is it a broader shared responsibility, or is it a governmental responsibility, just at a high level? And then I have some questions about how does that really, manifest over time? So at a core, whose responsibility is this?
I'm going to say something very controversial. It is not just everyone, it is the individual. And I know that's controversial because you might think, oh, this is a vulnerable population. They are probably subject to circumstances in their lives that they were not responsible for. However, that doesn't deny that every single person in this country, whether you're on commercial plan, you're on, on exchange plan, you're on Medicaid, you have a responsibility to take care of your health to the best of your ability.
Yeah.
And I would argue that when we all collectively take responsibility, the health plan, the individual, the community, the federal government, the state government, we have a much better shot at producing a healthy population because we're all invested in it together. And I think that the more individuals can take advantage of the opportunities from wellness to prevention, the better off you will be as a human being, and the better off the whole system will be because we're all invested in it together.
Yeah, fair enough. Well, I want to dive into that very controversial point here in a little bit, but we're going to take a break, and we'll be right back with Paige Brogan. All right, so we're back here with Paige. Paige, we were talking before the break a little bit about the challenges of having, all of the different programs and whose responsibility is it at the end of the day for those populations. A lot of the medical group leaders that are in our audience today are thinking about, what's the technology advantage? How do we use data? We talked a little bit earlier about how that information could get shared. Talk a bit more, if you can, about where some of that information has helped the program, where has some of that information and data been used in the program to improve a population, or maybe even change a strategy within a given population. Has there been some good use of that data?
I think we've started to.
Yeah.
I think one of the challenges has been we just don't have enough data, and we don't have really solid data sharing platforms. And that's really important because, as many people probably are aware, you can change your Medi-Cal plan every month. So if you leave Kaiser and you go to Molina, how do I know what services you were getting?
Right.
And so, more importantly, when you then go and leave and go to another Medi-Cal plan, how is that data being tracked? And how is the loop being closed on referrals that you may have in progress?
Right.
And so I think there's a lot more. And I sort of touched on this earlier. We're talking about brick and mortar encounters, claims data, but what about when you go to your church and you report either a clinical or a non-clinical issue that's related to whole person care? How are we getting that data? And how are we able to synthesize that data into a care plan that actually makes sense for you?
Yeah.
So I think there's a long way to go. I think that the state-run population health management system has potential. It's really kind of in its infancy. But I think that...
And describe that a little bit. That's sort of a HIE combined with some quality pieces, or how would you describe that?
So I would describe Medi-Cal Connect as a system in which the state is pulling data from anywhere they possibly can where they can find claims data.
Okay.
And pulling that into one place so that I can see, as a health plan, I can see for a member, I can see all of the information around their entire health history. So, the longitudinal kind of member record.
I gotcha.
And what that looks like. I think that data sharing is something that we continue to iterate on. I think that technology is there. I think that, obviously there's privacy issues, there's kind of access issues, but ultimately it has to be something that every entity along the healthcare spectrum for the Medi-Cal population is invested in and is willing to be a partner in.
And has there been mandates by the state that would encourage that sharing, or has there not been very much of that?
There has been, but a lot of it has been really dependent upon agreements between counties, between health plans. that we need to have more standardized data reporting requirements. We need to have more standardized data sharing agreements. And I don't think we're there yet. I think we're getting closer.
Yeah.
It's going to be a continual iteration.
And certainly we've had federal legislation and mandates to drive transparency, particularly around prices, of course, but the data sharing is also going to continue to improve. Decisions made by organizations like Epic, where they're agreeing to share more of their data out. But how does an organization that says, hey, we're Blue Shield perhaps, or another health plan, and the patient, like you said, is hopping around, and so now we have to collaborate not just with other health plans, but then track down providers within the network that they're going to, whether that's an ED or an urgent care or getting care from a street health team, that's today seems like damn near impossible. It sounds like. Is there any hope, or is there any work trying to help connect some of those dots?
I think there is, but I think honestly, Jason, it's on a case-by-case, health-plan basis, and I think there needs to be, honestly, there should be state and probably federal work that supports a much more stringent data collection process, and make it easy and make it very intuitive for the provider, whether that's a community-based organization, whether it's a street medicine provider, whether it's a brick and mortar. There should be a very easy way to provide that data into some central database whereby for the next person that's providing care, it's very evident what that care trajectory has been. And when I say care trajectory, I want to be very clear. It's not just clinical medical care, but it's, did they get a meal? Did they get some kind of behavioral mental health intervention at some point along the way that maybe wasn't in a traditional forum?
Right.
So, I mean, when you start to think about what the future of Medicaid on a federal level looks like, is you're really going to have to be open to non-traditional ways of collecting data for a non-traditional population. Yeah.
And so let's say, you wave your Harry Potter magic wand and all that data is now available to folks. What is an organization like, CalAIM and all the subsequent or the subsidiary health plans that are participating in CalAIM doing with that information, and how does that change the day-to-day for both the providers and for the patients?
I think that's a fantastic question, because I think what it leads to some predictive analytics where then I can identify, maybe Jane Doe has never been seen, but she went to a church group, and now I've got data that tells me something about Jane, and I can then reach out to her and say, hey, you know what? I think you should come in for screening X, Y, and Z, and I also think that you may be at risk for disease A, B, and C, and I can do some intervention before it ends up in a crisis situation. Yeah. Right? I mean, that's really where medicine should be going, is identifying in advance. Yeah. And because this reactive sort of posturing that the plans and the providers have been doing for decades is not effective. Yeah. It's not effective for plans. It's not effective for people. And so, how do we get into the game of really being able to identify before anybody comes in because they've got a pain, right? The better we can get, and this is across all lines of business, to be honest, but particularly in the Medicaid population, which has a great deal of vulnerability. So if I can figure out who you are and I can get to you, then it's better for the plan, it's better for the it's better for the person. Yeah. And so, talk a little bit about what you've seen in the market. Certainly you've talked to a lot of companies out there, both health plan entities as well as vendors and other technology entities. Boy, this wave of AI over the last 18, 36 months has been pretty interesting, pretty exciting. A lot of the clinical applications we've been hearing about, of course, are much more rote. How does radiology get impacted by AI? How does, something like triaging in the ED get impacted by AI? But what you described, I think, is a really interesting case of, can we, in a very cheap, very fast way, diagnose things or predict some potential health issues and try to intervene as quickly as possible? What have you seen out there that is starting to get into that? Did you dabble with that some so far at your previous role here at Blue Shield? And where do you predict that'll go in the next year or so? I think what's really exciting and interesting to me is some of the behavioral health models. A
Yes.
lot of the telehealth medicine opportunities with behavioral health are really fascinating. I think some of the gamification that we're seeing out there, so
Okay.
getting people to adhere to their prescriptions, for example.
Right.
And it's gamified. So you click on your phone every day
Yeah.
that you've taken your medication, and then after a certain number of days, you win a gift card.
Yeah.
And you could argue that maybe that's a little, simplified and trivial, but there's some good evidence that it works. And I
People
think
respond to incentives, and boy, there are a lot of apps out there, little casino apps and others that indicate that people will click on their phone for dang near anything all day long,
hey, I am very proud of my Wordle streak.
That's right. That's right.
So, yeah, and so I think that, the more we can be creative, I think the more we can be curious,
Yeah.
the more we can adapt. I think that, when we think about the old school version of, you go into a brick and mortar, you get a diagnosis, you get a prescription, that way of thinking is no longer going to be applicable.
Right.
And this is not just for Medicaid. Again, I think it's across the whole spectrum of the lines of business, but
Yep.
particularly within Medicaid, because it is such a unique population, people... health plans and healthcare delivery systems are going to have to be adaptable
Yeah.
and really think about what are the needs. I mean, it's interesting, Jason, because 10 years ago, when you talked about giving somebody that was on Medicaid a cell phone, people said that's crazy.
Right.
They use their cell phones more than any other line of business.
Yeah.
And so, you have to kind of start question your assumptions about this population. You have to start being creative. You have to be curious. You have to really see what is working, how are we meeting people where they are.
Yep.
And the more we can get data about, I think the street medicine, field medicine, whatever you want to call it,
Yeah.
I think a lot of those providers have a really great insight because they really are meeting people where they are. And so, we can get some of the, sort of anecdotal evidence, so to speak, and bring that back to health plans to help us really create innovative solutions. That is where we need to go.
Yeah, and I imagine that the fact that it can be done so quickly with AI, right? I mean, you and I both are probably using it every day on various,
Of course.
things. And for somebody that's in the field to be able to access it with, a GTE enabled or a Wi-Fi enabled device really quickly, and cheaply too, right? I mean, the fact that the street medicine folks, the community health providers can access all this information, all of this insight in a fast and cheap way really is promising that we might be able to make a dent in some of the challenges that this population has, I feel like,
100%. And I, obviously we have to think about speed and cost, but I really want to emphasize that from a health plan perspective, it's not that we want to deliver something fast and cheap. We want to deliver something that is efficient for both the plan and the individual and the provider,
Yeah.
right? So, I mean, when I think about it, I don't think about it in terms of, we want to save money or, we want to get it as quickly as possible.
Good point.
We want to get it in a way that is efficient, that
Yeah.
makes the lives better for our members.
Yeah. Yeah, and in order to get access or get a line into some of the benefits that they're probably know that they have in their plan, using that information and using that technology to get to that point more quickly and efficiently, I think is a great way to describe it, because access is an issue for no matter what kind of health insurance you have, and so if we can get to folks a tool that will allow them to get into that much more quickly and efficiently, I think I'm all for that. What are your thoughts on how that again continues to connect with, right? So certainly the relationship between health plans and health providers is an interesting one. It's a relationship. It's a dance, if you will. But I think everybody that's a collaborator in a program like CalAIM is looking to improve the overall health of the broader population. And so the relationship between those two entities is enhanced by more data, it sounds like. And the relationship between those two entities could be made more efficient and improved by some tools like AI tools. Do you see that continued sharing of risk pools, just from a pure financial standpoint, is the only financial mechanism that we think will kind of get us to that endpoint? Are there other financial or incentive mechanisms that you've explored that might be an alternative to something like a shared risk pool?
Well, I think value-based care is definitely an area where I think Medicaid, again, speaking on a federal level, there's lots of opportunity there, right? We should have value-based contracts with our providers. We should have specific metrics that we are asking them. And, maybe you tie it into HEDIS measures, maybe you don't, but, you definitely, I think, want to encourage a model whereby they're based on performance. How many screenings are you doing? How many times are you making sure that somebody has adequate food to eat?
Right.
And then I even think, again, going back to this idea that we all have a responsibility here.
Yeah.
You look at medically tailored meals, for example, just because you're delivering 5 meals to a person every week, are they eating those meals? Are those going in the trash?
Oh, right.
I mean, so really looking down at the nitty gritty of all of the delivery entities and those outcomes. So just because it's available doesn't mean that it's being utilized. So how are we measuring that?
Right.
Looking at transportation, for example, transportation in the Medicaid space is incredibly expensive.
Yeah.
So are we evaluating that? Are we making sure that we're getting people to the right provider at the right time? How are we looking at, and it's a real thing, how are we looking at fraud, weight, and abuse in the Medi-Cal space, right? And especially with CalAIM, you've got a whole new suite of services. Home modification is a good example.
Right, yeah.
So, how are we checking?
Are those handles really getting installed? Are those ramps really getting put in, et cetera? Right,
Right, and are they being used?
Yeah.
I think that's the other question we have to ask ourselves is,
Interesting.
All of these things that we're offering to people, are people eating the meals? Are they using their ramps? Are they using their transportation appropriately? So that's where I think accountability is across the entire landscape.
So I'm curious because I would love for you to describe in a little bit more detail some of those different types of programs. Like you mentioned, the food, there's a whole food as medicine sort of movement out there in the marketplace. Certainly credits and ways to pay for getting you to the pharmacist or getting you to your appointments is a huge barrier for a lot of Medicaid folks. What are a few of those programs, just so the audience kind of understands a bit about what we mean when we say some of these programs are addressing some of the social determinants of health, right? I know SDOH has been sort of had a little bit of a meteoric rise and fall in terms of a term of art that folks have used, but all of those externalities that are blocking folks from being well, from getting the care that they need. Talk a little bit about some of the specific programs that are serving those needs and populations.
Sure. So medically tailored meals is a community support. So it's an optional opportunity for health plans to provide, to in your words, food is medicine. Some of it's food as medicine. Some of it's just I don't have food.
Right. Yes. Of course. Yeah.
And so the plan's idea was contracting with providers that provide specific meals, and we've seen there's been a lot of success. We've also seen freezers of food that's never eaten. We've seen situations where food is delivered and there isn't a microwave, or there isn't heating apparatus,
right?
Or there isn't refrigeration, so the food spoils. So, I mentioned this earlier, you really have to get down to the nitty gritty of meeting people where they are and really understanding what the situation is. So maybe in some cases, you give them a voucher to go to and it's funny because I was just listening to a gentleman whose name I can't remember, but he's a big food agri person, was talking about the fact that a lot of ultra processed food is actually not that bad for you, and so maybe we end up giving someone some shelf stable food situation, right? I know we all had this brilliant vision of Alice Waters delivering an organic meal,
organic vegetable salad But to your point, if there's no refrigeration, there's no way to cook it, then it's no better than nothing, to some regard.
Exactly. So, so this goes back to the notion of we have to be creative and we have to be adaptable and we have to kind of suspend assumptions, right? So we think we want to deliver something to somebody, but we have to ask ourselves, is that really what they need? And is that really the thing that's going to help? Because if you give somebody a shelf-stable meal that is going to be consumed and eaten, that is far more effective than your organic veggie box.
Right, that spoils in a day and a half or what have you.
Exactly.
So taking some of those findings, right, have you been effective, or has the group, the collaborative, been effective at adjusting some behaviors, right? Because I could see that realization coming to light, being like, hey, we delivered 500 meals, but guess what? 30% of those didn't actually get eaten because of one of these 3 or 4 major reasons. And so to address that waste part of the fraud, waste, and abuse, right? That's certainly not an abuse. That's just a waste because we didn't think about some of the nitty gritty details, like you said. Are they making adjustments? Are they bringing, maybe a cooler or maybe different types of meals, shelf stable, for example, to those households where they don't have the facilities to cook or to refrigerate?
I think the rural counties have actually been very successful in innovation.
Yeah.
Necessity is the precursor,
the mother of invention, right? Yes.
Yeah, exactly. So, in rural communities, they've had to be innovative because they don't really have some of the other features that you see in more of the urban centers, the Bay Area, Los Angeles County, San Diego County. So we've seen some of that, but I don't think we've done a good enough job of codifying that in a data way whereby it's spread across, right? So, and when I say data way, that's a very unscientific term for saying basically, it hasn't really been codified in a metric sense whereby it can be shared across all the health plans, all the stakeholders within CalAIM, right?
Yeah.
The community-based organizations, behavioral health organizations,
Right.
counties, et cetera. And so I think we need to do a much better job of capturing some of those single use cases into a broader context to be shared for people to start thinking, oh, yeah, my best intention really is not effective.
Yeah, because I think a lot of folks want to continue to serve these populations and have great ideas in how to do that, but sharing background information, helping folks to identify solutions to get through some of those barriers is such a challenge. How does some of that information get shared out? Have you guys and some of the collaborators published white papers? Certainly you've spoken at other conferences and in other venues like this where some of that messaging does get out and people can understand, oh, yeah, if I have a program where we're working with a Medi-Cal or Medicaid population, that we need to learn from everything that happened over the last 6, 7, 8 years in California, and let's adopt some of those practices or change them, right?
I think they're very widely expressed. I know I've been honored to be part of the Los Angeles County Sustainability Collaborative, amazing organization run by Transform Health. And we share those, and they are documented. Are they widely distributed? Is it in some kind of central database where I can find, in rural, rural Northern California county, they did X, and I can go into a database and I can find that easily, right? No. And I think that's, to your point earlier about data, a lot of times when we think about data, we're thinking about, okay, I want to know, the metrics around the diabetes population, right? But I mean, that's a data point, right? So if I know in one county, they change their meal delivery program.
Right, and they had an 80% increase in whatever.
Exactly,
yeah.
Or, 20% decrease in waste.
Yes.
Then that's fantastic, and that would be great if I knew that. We just don't have that, and so, I would make a call to, this DHCS to figure out if, is there some kind of way that they can start codifying that into a way where any health plan or any stakeholder in the whole infrastructure can find that out.
Yeah. And as you're describing that, I'm sort of envisioning a future where much more rapid data sharing combined with wearable devices that provide some information about things like medication compliance. Maybe there's some, food meal compliance in some way, right, as well. And then you've got your testing. If that person has a diabetes and they're doing a regular testing on a regular basis, weights on a regular basis, other medications, etc. All of that goes into the stew. AI is pointed at it, and maybe that helps us in some way. What are some of the fears that have come up when you've maybe proposed that type of approach? Have you guys talked about that in committees and other organizations internally?
I think that there's been conversations among stakeholders about, how can we do a better job? My vision is, you think about, any kind of organization has their technology, and it's, in today's world, you put it in user stories, right? So I want to, change one of my internal IT systems, right? I create a use story. Why can't we use that across all of the different experiences we have within CalAIM, right? You got some one, central Jira database with all these use cases, right?
Right.
Obviously privacy is key, right?
Sure.
That's always going to be an issue. And I think there's still some people that don't like the idea of data sharing, right? I will say one of the things that has been very impressive about CalAIM is you've really seen a huge amount of collaboration amongst the plans. And I think plans do want to share data because they recognize it's to everyone's benefit, right? If, again, as I mentioned earlier, if you move from Kaiser to Molina, in a month, it's helpful to me so that I know what medications you've been on. I get your whole story. And, a lot of this is an Epic, but I mean, for some of the non-traditional services, meals and things like that, right?
Yeah.
If I know that story, I can deliver on the promise of care in a much more effective way.
Yeah.
But, there's still people that I think are anti-data sharing.
Yeah.
I think that's changing. But you need, if you want to be in the Medi-Cal space, you've got to be innovative. You've got to be open to change. You've got to be open to doing things differently than you did before.
Yeah. Because of that, are there any magic metrics? Are there any indicators that you feel like you guys have come across? And when I say you guys, the Medi-Cal collaborators, are there any particular metrics, one or two or three things that you say, look, if we can monitor these and lower the incidence of X, that is a strong correlation to a whole slew of things that will improve the overall health of our population, because we're not able to get to the granularity like you talked about. We can't have 100 data points that we're looking at for every single population. So are there proxy metrics that say, okay, if we can monitor these three things, that will get us a pretty strong correlation to a lot of positive outcomes?
Well, the number one is the reduction in emergency room visits, right? That's been the number one thing that we've definitely seen. And I think that's amazing. I think it's, truly a testament to the program really working. We see people going to the emergency room less. We see our closed loop referrals are definitely up, right? So we're able to see, okay, we referred somebody to a specialist. They actually went to go see that specialist.
Right.
And we're able to see the outcome. So I think that would be the other one that's incredibly indicative of success of the program. And then I think finally, I do think that the collaboration between all of the various stakeholders within the healthcare delivery system, I think the fact that we're at the table, we're talking, I think the fact that DHCS is listening to healthcare plans, I think is incredible. So I think there's been incredible efforts in that space. And I think the fact that providers are willing to do value-based contracting and willing to deliver in a way that they didn't before, I think that's another indication that the program really has succeeded.
So then what's the outlook for CalAIM? As you mentioned, the initial grant from the state was, a 5-year grant, right? And there's certainly some support from the federal government to continue some of the programs, but that ran into a little bit of a speed bump here last year. What's the medium-term prognosis of the program as we think about, the next 2, 4, 6 years here?
I think you'll definitely see plans push back on community supports. I think you'll see plans start to eliminate their community supports.
Okay.
I think
because there's not a link to effectiveness, or because it's farther down the priority list. Like, why is that? Because it seems like that would be the first rung of keeping somebody out of the ED, right? If you're able to provide some of those community supports, that breaks a cycle of 2 or 3 escalation points later on.
Yeah. I think a couple of reasons. One is you're not seeing the utilization as much.
I see.
The other thing that you're seeing is some of these providers really were boosted up by grant money, and that's drying up. So you're going to see providers leave the market. So you're going to have less providers. And then obviously because of HR1, you're going to see fewer Medi-Cal recipients, right? I mean, we know that we're going to just see the population is going to be reduced.
Right. Because the subsidies were reduced and the threshold, the poverty threshold, and all that sort of stuff.
Well, not so much the subsidies, Jason, but more just because of the work requirements. So
right. Yes.
Work, volunteer, school requirements, and also redetermination is going to be more challenging.
Okay.
So we're going to see a loss of members in the market. So you're going to see less providers. I think that you're going to see a return to a more classic Medicaid federally, right? You're going to see. I think you're going to see some of these whole person care components. Sadly, I think you're going to see them diminish, right? I think you're going to see people going back to a more classic Medi-Cal where it was just, very strict, narrow definition of the services that you received.
Yeah.
And I think that's really unfortunate because I think that what CalAIM did was it really exposed that there was a big gap, and whole person care is really the right way to approach it.
Yeah.
To what degree will the community-based organizations be able to pick up that slack? I don't know. I think that it'll be very dependent upon sort of how the state maybe borrows from ideas of other states that maybe have done things at a at a less scaled. And I think that if we continue to be innovative, we'll figure out a way. But I do think that it's going to be a hard time for Medi-Cal for the next few years.
Yeah, and I is that just the pendulum swinging back and forth, or do you think this is a little bit of more of a longer tail trend in that direction?
I think it's both,
is
to be
it?
honest.
Okay.
I really do. I think
Okay.
there is a little bit of a pendulum swing in terms of, there are people that have argued, gosh, there are people on Medi-Cal that have a better health plan than I do.
Right, sure, sure.
People that are on an on-exchange program that they're paying a lot of money for. I think there's long been a standing belief that people should have more skin in the game. And I mentioned this earlier. We all have accountability and responsibility.
Right.
So, I think asking someone to do some kind of income-adjusted copay is not necessarily an insane idea.
Right.
And so I think you're going to see, I don't think you're going to go backwards. I think you're going to see a new way of doing Medicaid on a federal level, and certainly in California, a new way of doing Medi-Cal. And I think that's the right way to go.
Yeah. So, as we mentioned, you're moving to a different role here pretty soon, but not to get too nostalgic, but as you look back at your intense kind of role within CalAIM over the last several years, what's one or two things that you look back and you think back, boy, that was a really cool thing, or a really cool program that we pulled off, or maybe a lesson that you learned in working with this population over the last 5 years?
I think what we achieved was absolutely phenomenal. I think that the amount of blood, sweat, and tears that went into delivering a lot of very complicated programs, calling on a lot of stakeholders to become engaged, to work hard to something that everyone really believed in, I think is absolutely extraordinary. I think what California did was truly, truly amazing. And it will change, it will, continue to iterate, but I think that the work that we did over the last 5 years is something that everyone that was involved should be incredibly proud of. I think it was a very, very unique, special program. And I'm personally just so honored that I was able to be a part of it. Yeah.
Now, to be clear, it's going to live on in some way, shape, or form here, right? It's not completely dead, right?
Yes.
You're talking a little bit like it's ending at the end of the year now, but it's going to continue. It's just your involvement won't be nearly in the same vein.
And to be honest, enhanced care management is a benefit, so that will continue, right? Regardless of what happens with the waiver, that will continue. And I think you'll continue to see innovations in Medi-Cal, and I think it'll be really interesting to see what the state does with its population health management program, Medi-Cal Connect. So, really interesting to see how that evolves and how the data opportunities evolve for plans and members.
Yeah. And is there any predictions, or is there anything that's going to drastically change, you think, that could have a humongous impact in the next 5 years on the Medi-Cal Medicaid program as you're now moving to a little more provider-facing role? Is there anything that you're thinking, boy, if this one thing happens, it's really going to be a game changer for Medicaid?
I think there's going to be two things. I think the adoption of AI to support the population will be huge. To what degree plans take advantage of it is open question. I think the big thing is obviously who's our next governor.
Sure.
And
to
what priority do they put on healthcare?
Right. Yeah. No, that is huge. But so obviously you're moving on to a different role. What are you excited about upcoming, and is there something that is getting you jazzed about your new role?
Oh, I'm excited to support the provider population, and I'm just excited to continue to see how healthcare innovates and how I can be a part of that. Absolutely. Well, listen, as somebody that has put a lot of time and effort into a very challenging program, very challenging population, applaud all of your efforts, and in the time that I've known you, just really innovative ideas and really cool things that you guys have all done, and spearheaded by you and the program and the committees that you've worked with. So thank you so much for that effort. Thank you, Jason.
Yeah. Well, appreciate you coming on today. I know you got to go, but really enjoy the conversation, and look forward to future successes from you.
Thank you, Jason.
So that's our show for today, System Logic. Paige Brogan talked a little bit about the CalAIM program here in California, how we're serving the Medicaid population, the whole person care, and how other states might learn a few lessons from the Golden State. So if you want to hear more conversations like the one I had today with Paige, please like and subscribe to System Logic Podcast wherever you find your favorite podcasts. So thanks so much, and we'll see you next time.